Hello everyone, in today's video we will be learning about metabolic acidosis. As we all know, metabolic acidosis is primary bicarbonate deficit. This results from accumulation of acid or depletion of bicarbonate. So we have the Henderson-Hasselbalch's equation for bicarbonate buffer pH equals 6.1 plus logarithm of HCO3 by H2CO3. So what happens in metabolic acidosis? pH is decreased. And what change you are expecting in HCO3? HCO3 values also should decrease because pH is proportional to HCO3 concentration. And in this case, the ratio will be less than 20. When there is excess acid production in the body, the bicarbonate is used up for buffering. Now, moving on to the causes. So, we have three main causes. The first one is increased production of acids in our body. So what are the causes of increased production of acids? The first one is ketoacidosis. Second is lactic acidosis. Third one is the consumption of poisons or toxins and drugs. So in these headings, ketoacidosis, the most commonest causes are DKA, diabetic ketoacidosis, and starvation. Lactic acidosis, the rate of production exceeds the rate of consumption. What are the poisons involved? Methanol, ethylene glycol, and salicylate poisoning. So the metabolism of methanol, it can produce formic acid in our body, which leads to increased production of acids. Now ethylene glycol, on metabolizing, it is converted to glyoxylic acid and oxalic acid. Now moving on to the second cause, that is decreased excretion of acids. So what are the two conditions which cause decreased excretion of acids? The first one is renal failure. Second one is renal tubular acidosis. So regarding these two causes, the renal failure, it is a commonest cause for high anion gap metabolic acidosis, HAGMA. Renal tubular acidosis is a commonest cause for NAGMA, normal anion gap metabolic acidosis. We'll be discussing in detail in this video later. Now the third cause is increased loss of bicarbonate ions, especially in diarrhea. Now, moving on to the next topic, that is anion gap. What do you mean by anion gap? It is sum of cations minus sum of anions, Na plus plus K plus minus Cl minus plus HCO3 minus. So the normal reference range is from 10 to 14. Now in some cases they won't give you K plus value because when compared with the sodium value, K plus value is negligible. As I said, normal range is from 10 to 14 millimole per liter. So anion gap indicates the concentration of unmeasured anions. What are the unmeasured anions? Protein anions, sulfates, phosphates, other organic anions like lactate or acetoacetate. So this is one example where all the electrolytes values are given and we have to calculate anion gap. So we are applying this in the equation, that is 138 plus 4 minus 105 plus 25. You will get 12 millimole per liter within the reference range. Now we are moving on to the pictorial depiction of anion gap. So this is the normal case. We have normal K plus sodium chloride HCO3 and normal anion gap. Now we are moving on to the topic metabolic acidosis. In metabolic acidosis, HCO3 anions are decreased, right? So to maintain the anion gap, chloride anions has to be increased in our body. So what if this is not happening? Then the anion gap will increase. So this type of metabolic acidosis is known as high anion gap metabolic acidosis, otherwise known as HAGMA. Now we are moving on to the next scenario. So again we are discussing about the metabolic acidosis itself. So what happens in metabolic acidosis? Bicarbonates levels will be decreased. So to maintain the anion gap, chloride ions has to increase in our body. So this type of metabolic acidosis is known as normal anion gap metabolic acidosis. So I hope you have understood the concept of HAGMA and NAGMA. Now we have to discuss about the causes of both these conditions. The first one will be HAGMA. So we have a mnemonic to remember the causes of high anion gap metabolic acidosis. They are Dr. Maples. Dr. Maples. D for diabetic ketoacidosis. R for renal failure. M, methanol poisoning. A, aminoacidurias. P, paracetamol poisoning. L, lactic acidosis. E, ethanol poisoning. S, salicylate poisoning. So these are the causes of HAGMA, and I just want to highlight renal failure in the causes of HAGMA, because here it is the chloride anions are not increased. That is why the patient is having high anion gap metabolic acidosis. Now causes of NAGMA, again we have a mnemonic, that is does RT gap. D for diarrhea. U for ureterostomy. S is for small bowel fistula. RT together it is renal tubular acidosis. C, carbonic anhydrase inhibitors. A is for adrenal insufficiency. And the final P is for pancreatic fistula. Again, here in this case, I just want to highlight renal tubular acidosis. Why? Because here the chloride ions are increased to maintain the normal anion gap. Now moving on to the clinical features of metabolic acidosis, there will be increase in rate and depth of respiration. It is termed as Kussmaul's respiration. Now regarding the compensation, so since it is metabolic disorder, what compensation you are expecting? The primary compensation should be by lungs. So if there is stimulation of chemoreceptors by decrease in pH, it will result in decrease in PCO2. Now the secondary compensation can be done by kidneys. So what happens in kidneys? There will be excretion of acids and NH4 plus ions, and there will be regeneration of HCO3 ions. So these are the main compensatory mechanisms that is happening in our body. Now moving on to the types of metabolic acidosis depending upon the compensation. So as we all know, according to Henderson-Hasselbalch's equation, pH is proportional to HCO3 by PCO2. So metabolic acidosis means pH is decreased, HCO3 is also decreased. Here in the first scenario, PCO2, there is no change, that means there is no compensation. That type of acidosis is known as uncompensated metabolic acidosis. Here the ratio will be less than 20. So now we are discussing the second type. So in this scenario, the lungs came in action. It is trying for a compensation. So what happens? PCO2 is decreased. Then only the pH will go up for normalizing the body's pH. So this type of metabolic acidosis is known as partially compensated metabolic acidosis. Here also the ratio of HCO3 by PCO2 will be less than 20. The third scenario, here HCO3 is decreased, pH is decreased, so PCO2 is further decreased to maintain the normal pH. So in this particular scenario, HCO3 is decreased, PCO2 is decreased and pH is normal. That means the body attained full compensation. So it is fully compensated metabolic acidosis. Here the ratio will be 20. Now moving on to the relationship between metabolic acidosis and serum potassium. So what happens in metabolic acidosis? There will be increased H plus concentration in blood. So H plus, it moves into the cells to reduce extracellular acidity. So to maintain the electroneutrality, K plus will move out of the cells. So what happens? More and more K plus is present in our blood. So it results in increase in potassium. That means hyperkalemia. So metabolic acidosis is associated with hyperkalemia. Now we will discuss an ABG data. So here pH is 7.32, HCO3 16, PCO2 44. So what is the normal reference range for pH? 7.38 to 7.42. In this condition, pH is decreased. So that means it is acidosis. Normal HCO3 is 22 to 26. In this case, HCO3 is again decreased. So that means metabolic. So this is metabolic acidosis, and PCO2 there is no change. So we are terming it as uncompensated metabolic acidosis. So next is the second data. In the second data, a 42-year-old man came to emergency room complaining of shortness of breath and had rapid and deep respiration. These are the ABG values. pH is 7.26, HCO3 12 and PCO2 29. pH is decreased, HCO3 is decreased, PCO2 is decreased. So that means it is metabolic acidosis and the body is trying for compensation. That is why PCO2 is decreased. So it is partially compensated metabolic acidosis. Now whenever we are discussing about the ABG disorders, we have to learn about the formula for calculation of compensation. So in this case, for metabolic acidosis, the compensation formula is known as Winder's formula. So this predicts the appropriate respiratory compensation in metabolic acidosis. So predicted PCO2 equals 1.5 into HCO3 plus 8 plus or minus 2. So we will see how we are going to calculate the compensation. So this is one of the ABG data, a case of diabetic ketoacidosis, and these are the ABG values. pH is 7.28, HCO3 is 12, PCO2 is 26. So as we all know, DKA is a case of metabolic acidosis. We have studied under the causes of metabolic acidosis. PCO2 equals 1.5 into, here what is HCO3? It is 12 plus 8. So now we have to calculate this value, and to specify the range we have to do plus or minus 2. So here the value we are getting is 26. 26 plus or minus 2 will give you the range. So it is between 24 to 28. Since observed PCO2 is 26, which is equal to the expected compensation, that is between 24 to 28, respiratory compensation is appropriate in